Deterioration in a patient's respiratory status can happen at any time while you provide anesthesia. In this video, we are going to show you the management of two different respiratory-related intraoperative emergencies.
Hey Finkel, I'm here to relieve you for lunch.
Hi, thank you. Let me give you a report on him. This is Mr. Gus. He's 46-year-old male. He's under general anesthesia for inguinal hernia repair. He weighs 70 kilograms and he's 6 feet tall, and has a history of cigarette smoking. He smokes 1 pack of cigarette a day, and no other medical history. He got intubated uneventfully 20 minutes ago, and he's tolerating his anesthesia well.
Okay.
And his vital signs, EKG monitor, he's running normal sinus rhythm, heart rate's in the 70s, blood pressure is normal, anywhere between 120s to 130s, systolic and diastolic is in the 50s and 60s. His ventilator settings, he is getting 600, his tidal volume is 600 and his rate is 12. He has an I ratio 1:2. His peak inspiratory pressure is anywhere between 15 to 20. And then he's getting 2% of SIBO. Okay. And his ET tube is taped to 24.
All right.
Anything else?
No.
Okay, thank you.
What's next?
The initial signs of mild bronchospasm can be subtle changes from the patient's baselines. Some initial changes you may see in your patient are increased inspiratory pressures and increase in end-tidal CO2. You need to note the change in your expiratory phase of your capnograph. As bronchospasm becomes more severe, you will see more pronounced signs of impaired ventilation. Some of the signs you may see include decrease in your SpO2, your ventilator may start alarming peak airway pressures, and you will have more difficulty delivering your tidal volumes. Your end-tidal CO2 will continue to climb. One must begin treatment to improve ventilatory status while ruling out other potential causes of impaired ventilation. First, you need to increase your FiO2 to 100%. Auscultate your patient's lung fields. Check to ensure that the ET tube is not endobronchial or resting on the carina, as it can move during positioning and surgery. Next, attempt to relieve any type of mechanical obstruction by suctioning or unkinking the ET tube. After you have completed these steps to rule out other potential causes of impaired ventilation, you can make the diagnosis of bronchospasm and begin your treatment. If the patient is still exchanging air, consider the following. First, deepening your inhaled anesthetic agent. Second, begin to administer a beta-2 agonist nebulizer treatment. Albuterol, for example, deposits to a large degree in the upper airways and tubing. Titrate to effects, 10 to 20 puffs may be required. Then reevaluate your patient by listening and looking at the monitors. If the patient does not respond to these interventions, or if the patient is not exchanging air, you must then consider a bronchodilating IV agent such as ketamine, 0.2 to 0.5 milligrams per kilo, or propofol. Lung sounds are noted bilaterally, then administer epinephrine 10 to 100 mics IV, titrate to effect, and note that you may need to give 1 milligram in a true anaphylaxis or CV collapse. Then reevaluate the patient. Listen for bilateral breath sounds. When they are noted, you should see an increase in SpO2, a decrease in your inspiratory peak pressures, a decrease in your end-tidal CO2, and your expiratory phase of your capnography should become more normal.
Other treatment options you could consider for more long-term treatment of bronchospasm include IV or subcutaneous terbutaline, IV aminophylline, IV or inhaled lidocaine to decrease histamine-induced bronchospasm, anticholinergics given via nebulization to decrease secretions, or steroids if it's due to inflammatory disease such as asthma.
Common cause of a blocked ET tube include biting, kinking, external compression, secretion accumulation, and intraluminal material accumulation. Depending on the cause, ventilatory changes with mechanical obstructions may develop over several minutes or in seconds. Peak airway pressures are noted to be increased. Tachycardia is also observed. The end tidal CO2 will be decreasing. Note the slow rate of rise in phase 2 and little to no phase 3. Starting with the patient, work your way back towards the machine. First, increase your FiO2 to 100%. Then listen to breath sounds. In this instance, no breath sounds are noted. Then check your ET tube position. Attempt to pass the suction catheter down the ET tube to check for and aspirate a mechanical obstruction. Resistance is met and the catheter cannot be passed down the ET tube. Consider patient positioning, particularly if neck flexion is being used, if the patient has any history of stenosis in the laryngeal structures or in pediatric patients. If the obstruction is unable to be removed, it is necessary to remove the ET tube and replace it.